Well, thank you very much, Cos, and thank you to the Pharmacy Guild for inviting me to present at the New South Wales Pharmacy National Convention and Exhibition today. And hello to all members of the Pharmacy Guild who are watching from around Australia. The Coalition have always understood the importance of a strong pharmacy sector in Australia, and we are keen to see that continues. I'd like to make some comments on, firstly, the Pharmaceutical Benefits Scheme and the listing process. The Coalition have given a commitment to restoring transparency, certainty and confidence to the process for listing medicines on the Pharmaceutical Benefits Scheme. The Cabinet interference by the current government of PBAC decisions and difficulties in getting certain new medicines listed has caused a loss of confidence in the listing process. We understand the importance of transparency and will restore this if elected in September. On the subject of investment in health and medical research, Australia enjoys enormous success in medical research, punching well above our weight for medical research publications. We've got much to be proud of regarding our successes in medical research. Funding for research is the best long-term investment a government can make in the health of the Australian people. Consistent long-term funding of medical research lifts national productivity, improves quality of life and life expectancy, and takes pressure off the hospital system. In the past decade alone, Australia's health and medical research sector has produced 3 Nobel Prize winners. The Coalition understands the importance of funding certainty in this area, and that is why we have committed to protecting medical research funding if elected. One of the areas that I'm responsible for is primary health care, and I wanted to talk about Medicare locals. The Coalition in the past, through the divisions of general practice, and in the future, will be supporting a coordinating role in primary care. There are 61 Medicare locals around Australia, some of which have transitioned from divisions of general practice, some of which have established as new bodies. They've been given over $171 million in core funding each year and another $500 million, almost $500 million, $493 million over the forward estimates. They also administer additional money on behalf of the Commonwealth in addition to their direct funding. And the government have just announced that they are extending the contracts of the 61 Medicare locals until June 2016. In this year's budget, the government announced $10 million to be spent on advertising a number of things on advertising the Medicare locals, on advertising the PC, the personally controlled electronic health record. And I've just seen one of the Medicare locals ads, and what an oversight. In talking about the whole primary care team, they have left out the pharmacist. Now, the opposition have been very critical of these ads. It was announced in the May budget. $6.5 million is scheduled to be spent by the 30th of June, and the rest of the money will be spent before the 12th of August, before the government goes into caretaker mode. This is blatant electioneering by the government, and it's being paid for by the taxpayer. On the issues with Medicare locals have been hamstrung from the beginning by the way that they've been established. By giving them such a broad focus, the Medicare locals are unable to really concentrate on what's important. Medicare locals have been tasked with assessing the health needs of their community and then attempting to address the gaps in health services that they identify. Now, I believe that Medicare locals actually need to have some very specific goals. And what we need is to be able to examine the performance, like for like, between the 61 organisations. By not giving the Medicare locals a specific focus with a few specific targets, the current government has set up these primary health care organisations to struggle. Now, we all know that there are certain things in primary health care which, if done well, will make a real difference. And you can think about, really addressing complications for diabetes, COPD, cardiac failure. The evidence is really strong that good primary care in this area can lead to reductions in preventable hospital admissions, it can lead to better care overall, and it needs the coordination and all elements of the primary care team working on it. Immunisation, screening rates, again, things which good primary care, we can see the evidence in those immunisation rates. Now, many of the health needs identified by Medicare locals as priorities in their local areas are not covered by the 31 clinical indicators being reported on by the National Health Performance Authority. So this is a real concern. The government have given the Medicare locals these 31 clinical indicators that they will be measured on, and yet some Medicare locals are going off doing their own thing. And this makes it a problem with actually addressing the success or failure of Medicare locals in their objectives and measuring their performance. The relationship and interface between Medicare locals and local hospital networks is overall generally poor. The interaction has not developed in the way it was first envisaged, and it's been further hindered by the lack of common boundaries between the two bodies. I want to talk a bit about coalition success with the divisions of general practice. The coalition was able to work with the divisions of general practice to quickly and easily drive change in the sector. One example is immunisation. By working with the divisions of general practice, childhood immunisation rates increased from 53% in the early 1990s to more than 90% in 2007. Computerisation was another area. There are, however, a number of Medicare locals that are performing exceptionally well to improve the health services within their community. One particular example is the Hunter Urban Medicare Local. It's a perfect example of how all the players in primary care, specialist, local hospital networks and Medicare locals are working together for better patient outcomes. There is a collaborative effort between the Hunter New England Local Health District and the Hunter Urban Medicare Local. It was designed as a response to GPs who identified rapid access to information about specialist services as a key tool to help them care most effectively for patients. These health pathways are being jointly developed by small groups of hospital, community and general practice clinicians called pathway development teams. Pathways are being created for each illness. These pathways provide GPs with on-the-ground information about local services. They provide information on assessment, management, hospital departments and referral, as well as patient information, reference material and educational resources. And it keeps clinicians up to date with which services are available, which are funded and how to access them. It's a perfect example of how primary healthcare organisations, local hospital networks, GPs, specialists and all of the primary care team can interface better to ensure more positive patient outcomes. I want to talk a little bit about the reporting on Medicare locals. The National Health Performance Authority commenced full operations in 2012. It was set up to monitor and report on all health provider services, including Medicare locals. It has been given $109.5 million to complete this task. Now, I have a real concern with the reports that we've had so far from the National Health Performance Authority. They were off to a slow start, but they've released 4 of their 5 reports in the last 2 months. 3 of the reports, which covered the out-of-hospital sector, their healthy community reports, of those 3 reports, only 1 of them contained any clinical information. That was their report on immunisation. And I have a real concern that by not producing the information on clinical information, which is so important, it's impossible to see which Medicare locals are performing well and which are not performing. There has been much more focus on patient experience, on really some subjective measures rather than concrete, objective clinical information. And so the second report, the first Healthy Communities report we had questions like, did you feel that your GP always or often listened to you? Did you feel that your GP showed you respect? Now, it's important to have measures of consumer satisfaction, but that should not be at the expense of clinical indicators, as I said, in those first 3 healthy community reports, 2 of them have had no measure on clinical indicators. As I said before, there are 31 clinical indicators that the NHPA is meant to be comparing and measuring Medicare locals on. And there's a number of indicators which I think should have been reported on before patient experience. What we really need to know is what are the levels of potentially avoidable hospital admissions by each Medicare local. That's the sort of thing that each Medicare local needs to be focusing on. What are the screening rates for the 3 national screening programs, breast, cervical and bowel cancer? What are the levels of primary care emergency department presentations by Medicare local? What's the prevalence of overweight or obese status by Medicare local? These sort of things would be much more useful than the sort of information we've seen so far. Now, the Coalition have said if we are elected in September, we will formally review the Medicare locals. Our priority is to ensure that Commonwealth health funding is directed to frontline health services that benefit patients and support clinicians. Any efficiencies or savings identified in this review will support further investment in primary healthcare services that directly benefit patients. The review will recognise general practice as the cornerstone of primary care in the government's structures. It will ensure Commonwealth funding supports clinical services rather than administration. It will assess processes for determining market failure and service intervention so existing clinical services are not disrupted or discouraged. It will evaluate the practical interaction with local hospital networks, including boundaries, and will examine tendering and contracting arrangements. At the same time, there is a Department of Health and Ageing review into Medicare locals. It's being currently conducted as an external evaluation by Ernst & Young. The evaluation started in January 2013 and will be handed down in June 2014. It will consider the extent to which Medicare locals as new primary healthcare organisations have achieved the following 5 strategic objectives that they were given. The review will also consider the transition from divisions of general practice to Medicare locals, as well as assessing the way Medicare locals are interacting with other health organisations. These 2 reviews will allow a future coalition government to assess the successes and failings of Medicare locals and ensure that they are focused in the most effective way possible on improving clinical outcomes for patients. Now, on the subject of e-health, the government have lumped all of the investment and focus in e-health into the personally controlled electronic health record. And we need to realise that e-health is so much more than just the PC EHR. In fact, the government's own e-health strategy document from 2008, prepared by Deloitte, complained about the frustration at the pace of progress then, and yet 5 years later, we just see very little progress from that point. Despite a number of reports suggesting a staged and incremental approach in e-health, the government have decided to go for the big bang, high-risk solution of the PC EHR. A staged and incremental approach would have allowed time for the system to develop and mature as it expanded. It would have allowed consumers and clinicians to be brought along for the journey, creating buy-in at the same time. The experience with computerisation in general practice was first they computerised, then as the patient record became incorporated in their practice, it changed the way they practice. Now, unfortunately, by having so much focus on the PC EHR, the government have taken their eyes off the ball in focusing on a number of the quick wins, and they've failed to ensure buy-in from health practitioners who would use it. As at the 6th of June, there were approximately 250,000 registrations of the PC EHR. Now, this was up from 70,000 registrations in March, which is a dramatic increase in the pace of registrations. But at the same time, there were only, across the whole of Australia, 1,928 uploaded shared health summaries. Now, the government's own target was 500,000 people by the 30th of June, and it looks like they'll fall a long way short of that mark. But the 1,928 shared health summaries is a much more accurate identifier, and the question has to be asked, after spending almost $1 billion to have less than 2,000 shared health summaries uploaded, has this been a good spend of money? Now, the Coalition would have done it differently, but we now have a PC-EHR which has cost almost $1 billion. Our focus is to ensure that we do have something useful to show for this investment. That is why, if elected to government in September, the Coalition will do a stocktake and review of the PC-EHR. We need to get a handle on what is and what isn't working. But our focus in the e-health area will be to focus on the things that were identified back in 2008 as easy, quick wins. Things like discharge summaries, paperless electronic prescriptions and pathology results. Now, e-prescriptions were a primary focus in the 2008 Deloitte e-health strategy, and it should not have taken this long to see e-prescriptions adopted. There are massive benefits in this once implemented, and I'd like to praise the work of the Pharmacy Guild for their work on the eRx script exchange. Paperless scripts are the next step. If the Coalition government is elected, we want to do everything possible to facilitate the uptake of e-prescriptions and paperless scripts, and this will be one of our focuses. So I would like to thank you very much for the opportunity to outline some of the Coalition's approach for a number of areas in the primary healthcare space. The pharmacists are a very important part of the primary care team. I'm disappointed that the government in their most recent ads has made the oversight of not including pharmacy. Thank you for the opportunity of outlining our approach on primary care and e-health. Thank you.